Feeling blue?
Good.
Good.
Good. We are called to create an even better and more just world.
And this is Creighton's response.
Reach out beyond boundaries.
And differences.
To serve those with needs.
Greater than our own.
This is Creighton.
This is Creighton.
This is Creighton in the community.
Hello and welcome to Creighton in the Community. My name is Joyce Bunger and I'll be your host. Life and death decisions are heart-wrenching, and often they're made a nurse is nearby. Today we are going to talk to two nurses who are well renowned in the area of nursing ethics. With me today is Dr. Winifred Ellen Child Pinch. She's Professor Emerita with the School of Nursing at Creighton University and the Center for Health Policy and Ethics. Dr. Pinch, before we begin, I know you are a forerunner in the area of nurse ethics. How did your career evolve so that you became a nurse ethicist?
Well, every nurse, including myself, encounters troubling situations which require moral decision-making. And so when I was a faculty member at a college in New England, I audited the course that the students were taking in ethics, since I had never had a bioethics course as a student myself. And I realized that their study provided a great deal of knowledge and skills that would be important in trying to make ethical decision-making in their practice.
You say bioethics. Is that different than ethics, or is it a form of ethics?
Well, it's usually used to apply to the situations that arise in healthcare. Some people say healthcare ethics, some people say biomedical ethics, some people say bioethics.
I see.
They're all kind of the same.
Thank you.
So as a result of that experience, I decided to focus on ethics in my doctoral program. However, this was the mid-70s, and there was no such thing as a master's in bioethics or a doctorate in ethics that is applied to healthcare. So, like many others in that same situation in the 70s, I devised my own program and studied it over the course of the 6+ years it took me to finish my doctorate.
Mm-hmm. And now, in terms of a nurse ethicist, your role is what? What do the nurse ethicists do? How are you different than another nurse?
Well, I think all nurses have a fundamental knowledge of ethics. They might bring that to their situation from formal study or from simply other experiences in life. But I think that the nurse ethicist has special skills and additional knowledge that they bring, either through a formal program or through self-study. Mm-hmm. And that enables them, I think, to become the faculty member who teaches the dedicated course on bioethics, or to be the clinical expert working in a hospital or agency where they are called upon for consultation in difficult cases. They might serve on the ethics committee, and they might also provide education to staff and other individuals in their setting.
Now, you have written a book called When the Bell Breaks. Tell us about that book and how you got to publishing the book.
Well, one of the things I studied, of course, in my doctoral program were ethical dilemmas in the neonatal intensive unit, NICU for short. And when I first began my role at Creighton at the School of Nursing, I was in community health. We had our own home health care agency at that time. And one of the assignments I had was to do follow-up with families as their infants were discharged from the NICU. So when I went to make these visits, I carried on conversations with the parents and discovered that their perception of their situation in the hospital was not what I understood to be the situation from my reading in my doctoral program. So I thought about this for a while, consulted with colleagues, and decided that it was worth focusing a research study in this area. So I was fortunate to get funding and be able to investigate this in detail. I interviewed families while the baby was in the NICU, as well as 6 months post-discharge and 4 years post-discharge. And the accumulation of all the information I got, plus some theoretical work related to that, are all in the book, When the Bow Breaks.
What were the ethical dilemmas?
Interestingly enough, parents could not define that they were really involved in ethical decision making in the hospital.
Like, what would be some of those decisions?
Well, how aggressive to be in terms of treatment, when to go to palliative care instead of aggressive care.
And palliative care is?
No aggressive treatment, simply comfort care.
Comfort care.
Caring, making sure the individual's not in pain, and providing all of the things that you would need to live but not be aggressive with medical interventions. They felt disenfranchised in general from decision making in that situation. And they also felt vulnerable in terms of making any confrontation, because the staff, after all, had the babies' lives in their hands, and they didn't want to, raise any kind of trouble that would impact the care of their infant. But when they got home, they realized that this was now their responsibility, and that perhaps they should have been more involved. Now, I want to make it clear that it wasn't that they weren't informed, because there is extremely detailed documentation of teaching that went on while the baby was in the hospital. But, they were stressed. They might not have heard it. They might not have understood. So that changes, I thought, needed to be made in the way parents were informed and the kind of
like what
materials.
Changes? I guess what I'm looking for here is, for our listener, is what are some of those rights, perhaps, or some changes that if you are in a situation with a loved one or yourself, that you do have, that things have changed that you can do?
One of the things that parents noticed is that they were sometimes told information while standing around the baby's isolette. They preferred someplace private, because the way the nursery was set up at that time is all the babies were in one room, and you could overhear families talking with the professionals at another isolette. So they wanted to go off to someplace private. The other thing is that they needed to hear the information more than once. So that written materials, videotapes, audio tapes were all important for them to have, which they did not feel that they got at that particular time. But changes have been made in the NICU, and some of those things have occurred since I did my research in the 80s.
Let's turn now to the Legacy Project. And I think that's just a nickname, or was it called the Legacy Project? What spurred the project, and what was the actual name of the project, or was it the Legacy Project?
Well, it takes too much time to say the whole name every
right.
time we wanted to
All right.
refer to it, so it's a shortened term. It's a nickname. But Dr. Amy Hatta and I had always wanted to do an nursing ethics project. And so after I retired from the School of Nursing, this was in the spring of 2005, she asked if I would be interested in working part-time at the center and carrying on this dedicated project. We were looking at nursing and healthcare ethics, the legacy and the vision. So we wanted to bring nursing ethics experts to Omaha for a working seminar in which they would discuss their work with other experts in the field. Having already written an essay looking at their own work, the legacy, and then its impact on the future of healthcare.
I suspect who were the older ones? I guess if I'm asking who, now I don't mean by old by age, I mean who were the long-term nurse ethicists, and what did they bring?
Well, actually by age, one of our oldest was Sister Simone Roach, who had been who was in her 80s when she came for the seminar. But there were other scholars who also began their career in this area in the 1970s. Ann Davis, Mila Roskar, Sarah Fry, and these were all people that we wanted to have involved in our project, and who in fact were involved in our project.
Of the 28 that were interviewed, were there 2 or 3, in your opinion, that were most memorable?
They were all special in different ways. It's hard to pinpoint one, but several stand out in my mind. Dr. Joyce Thompson, for one, whose work with women and her international influence is outstanding. Other individuals include Leah Creighton, who is a very outstanding spokesman and advocate for the problems and areas of troubling areas in ethics. And again, Dr. Mila Roskar, who is a very careful and thoughtful scholar.
What will future nurses learn from this video?
I think it is a unique opportunity to have these individuals do a critical examination of their own work and then look at what this means for the general area of ethics in nursing. I think it's important to have this book available for courses. The video only came out last May, so I'm not quite sure exactly. The book's been used in courses, but the video we're not sure about yet, but hopefully it will accompany the book. It enables people not only to read what people say, but it also enables them to see how enthusiastic they are about their work, to hear their tone, and to look at their nonverbal communication as well. It really highlights the essays that are in the book.
Thank you. If you would like to learn more about the Legacy Project and perhaps listen to the video, please contact Creighton University's Center for Health Policy and Ethics. And when we come back, we will learn more about nursing ethics. Is it intuition? Is it data? Or is it both? Joining me is Dr. Helen Stanton Chappell. She's an assistant professor at the School of Nursing at Creighton University and is also affiliated with Creighton University's Center for Health Policy and Ethics. Tell me a little bit about yourself and your career.
Well, I was a nurse at the bedside for about 20 years, before I came to Creighton about 3 years ago. And during that time, I got a couple of degrees from the University of Virginia. One was in ethics, and the other was in medical anthropology. I started out as a hospice volunteer before I went into nursing. My major interest has been most recently, is how dying occurs in the hospital.
Mm-hmm.
So,
how did ethics, what sparked your interest in ethics that you wanted to proceed in that area?
Along the way, I became very interested in the decision making that happens around patients who are severely ill. And I felt that, I felt strongly enough about it that I thought I better get a credential. And so that was available at the University of Virginia.
You're instrumental in helping craft the curriculum for the student nurses at Creighton University. Can you teach ethics? Or how do you teach ethics, I guess is a better question.
You know, it's interesting to notice the difference between morality, which we all seem to think we know, and ethics. Morality might be the difference between right and wrong, but ethics is going to be the difference between two rights. So if, for instance, a physician recommends a treatment and a patient refuses, both of them may be right, but which one should take precedence? So ethics is trying to talk to us and help us understand how to make those decisions and why one right might take precedence over another.
Do nurses often act as the facilitator then to helping the families understand the different issues?
They may. It really depends on the relationship and what's going on. The decision makers in the clinical situation are going to be the physicians and the family. The nurses are sort of the Greek chorus. Sometimes I think about them as sort of commenting on what's going on, but not without a lot of power.
Really?
In the situation. Right.
So in the curriculum, do you help the students understand the role that the nurses should play? Absolutely.
That even if they are not having a lot of power, they certainly have a voice, and they need to be using that voice. It's interesting that physicians are taught all the time how to talk in a clinical situation, but nurses generally are not given that opportunity.
Well, give me some examples of ethical dilemmas that nurses encounter.
Nurses are very close to their patients and their populations that they serve. And what they see, they witness a lot of suffering, they witness a lot of injustice. But as I said, they're not decision makers, so that they don't have the ultimate authority to change what they're seeing. So that causes them a lot of suffering in a sense themselves. They have to answer to a number of different entities, not only patient and family in a sense and the physicians, but also administration, to their colleagues, and to the profession itself. So there's a lot of tension involved in the position that they hold, and they need to learn how to negotiate that so that they don't get burned out and feel like they need to leave the profession because there's so much going on that they may feel that they can't influence.
All right, I'm thinking in visiting with Dr. Pinch, I know about the ethics of the NICU, Neonatal Intensive Care Unit. I know of ethics as it applies to right to live and die. What are some other ethical situations that I may encounter with either myself or my family?
Are you thinking in terms of your own? If you're thinking in terms of your own care or your own family's care, that's a very typical way to think about ethics in the United States, is about decision-making, autonomy, and choice. But in fact, especially here at Creighton, we're very, very concerned about social justice and the kinds of ethics that involve populations and underserved populations in particular. So nurses who are involved in public health, for instance, are very, very concerned with the populations that they serve. Again, it's wanting to give them more, wanting to get more, seeing ethical problems in a lack of solidarity, perhaps.
I see.
Serving those populations, so that we are sort of caught up in what we as Americans, schooled in self-reliance, get caught up in how we're going to be taken care of, rather than thinking about how it benefits us, in fact, if an entire population is healthy.
Oh, that's very interesting. I understand you've written a book called No Place for Dying. Tell me a little bit about your book.
The book, the entire title is No Place for Dying, Hospitals and the Ideology of Rescue. So I was very interested in how, as I say, how dying actually occurs. The decision-making, yes, but more importantly, how patients actually die in the hospital. So I interviewed clinicians, nurses, physicians, respiratory therapists who had taken care of a patient who had died recently. And that formed the basis for my book. And it's in two different hospitals that I did my research, a Catholic community hospital and a teaching hospital, to wonder about the kinds of pressures that the hospitals and the clinicians are under as they deal with making these decisions, and also as they deal with patients who are dying. It's very difficult for them to actually designate a person as dying, because rescue is so important to us for many reasons, and important to our self-identity. And we see it as an egalitarian thing to offer to patients. So that to say that you're no longer someone who's qualified to be rescued, who's eligible to be rescued, takes a great deal of effort on our part. We have to, I call it the ritual of intensification that we have to go through.
Where's the family in this process?
Well, the family's a big important part of it, because oftentimes by the time the patient is to this point that severely ill, often they can't participate themselves. They're too sick. So oftentimes it's the family that's involved, so that the team may come to a decision to say that a patient is no longer surviving, likely to survive. They would go to the family. The family would then either endorse or not endorse that decision. Often that's the way it works. But once the patient is designated as dying, they sort of become a second-class citizen in the hospital. Not to say they don't get good care, especially if they are able to get seen by palliative care, if that's available for them in the hospital. But the whole system doesn't see dying as a legitimate category. It makes it sort of second class, as I say.
How can families avoid discord at the hospital I'm thinking about what if a family member is dying of cancer, and there's heroic efforts that can be taken, and part of the family really feels that they want this to be implemented, and the other part of the family says, no, you know, let mom go. How can families avoid situations like that at a loved one's bedside?
Well, of course, your ideal is that this has all been talked about ahead of time and this is all settled. But in fact, that may not be the case. There may be estrangement in various family members, or they just don't want to talk about it ahead of time. But in fact, the thing that in real life situations, families are very, very stressed in these situations, and they're tired. Their schedules are disrupted, their lives are disrupted. It's a very, very stressful time. So clearly they want, what they would want to do is to access the resources in the hospital, the ethics resources, to help work through these situations. Communication is very, very important.
I don't want to spend a lot of time on this, but I have a personal situation I want to talk about. I have a very dear friend who is in a reoccurrence of cancer. One of the options to keep her alive is a very expensive drug, and there is some real the doctors seem to be in this camp, and the insurance company seems to be in this camp, and even the family is somewhat fractured. Is this where a board of ethics comes in, or how do you all, how can a nurse maybe be instrumental in helping bringing them all to the table, or how does that mend?
There is you're asking several different
questions. I know I am,
there.
and I'm sorry, but I guess it just occurred to me that this is an ethical dilemma that's right in front of me today. That in talking to you, it occurred to me that you might have some insight.
Well, anytime, to frame it in a particular way, anytime that someone is unable to get the care that they need based on the decision made by someone else, you're talking about rationing. And rationing is a problem anytime, as I say, people can't get the care that they really need. Other countries besides the United States have figured out how to do this so that their citizens can get the care that they need, other industrialized countries. But if you're talking about, it's who has the power in the situation. The question is, who has the power to make the decision? And even if there are certain factions that have particular sides, have certain interests that they want to serve, you want to bring them together. If in this case the family, the insurance company is not going to be in the hospital, but if there is if there's a bedside dilemma, you would want to call the ethics committee, the ethics consult service, whoever might be there, to try to work through some of these issues, and that would work for your family who's having discord.
So that's an option. All hospitals have these.
Actually, they all do. The Joint Commission makes it a core requirement that there's a mechanism of some kind in every hospital that you can call. It may be an individual, it may be a committee, but there has to be a mechanism there.
I have one last question. Healthcare reform is on the minds of many, and we can think of the economic arguments, and I know there are also ethical arguments. What is Creighton University doing right now to facilitate further discussion?
We are, at the Center for Health Policy and Ethics, we're often bringing people together. We are trying to reach out also to people in the community and also other centers nationally to try to promote these conversations. And actually, during the healthcare debate, such as it might have been, I mean, there was a lot of talking going on, but a lot in the press was a lot of scare tactics. And that was unfortunate because, as I say, there's a very, very real argument to be made about the interdependence of people in society and the importance that whole populations in a nation can be healthy and how that can serve everyone in the population. So we have done roundtables. We have Richard O'Brien as an expert in health policy, and he's done many, many outreaches into the community in different venues to try to talk about these issues and help people understand more in depth that they needn't be scared of healthcare reform. It's going to help all of us.
Thank you, Dr. Chappell, and I'd also like to thank Dr. Pinch for visiting with us today. To conclude today's show, we'd like to share some reflections of several of the trailblazers, the nurse ethicists who have helped craft this very important role for nurses and for healthcare. On behalf of all of us at Creighton University, thanks for listening.
I think what's surprising and a little bit disappointing is that some of the same issues that I was struggling with 20 years ago are still here. Who's in charge? Who has the authority to make decisions? Those issues are still with us.
I definitely think that our healthcare system is extremely broken, and I think that we won't really move toward a fairer or more just healthcare system until we address healthcare access issues and healthcare rationing head-on. We are burying our heads in the sand when we address issues of cost. We think that it should have nothing to do with healthcare decisions at the bedside. That's a luxury. We spend, more than twice what the other industrialized countries spend per person on healthcare. We have poorer outcomes, and we're rationing all the time.
And seeing the effects of poverty on people. And why this had to be, seeing children die because we couldn't even get a shot of penicillin for them. This was before Medicare or Medicaid. It was a rude awakening. That certainly was one of the things that led me to study ethics. Also, other things that I saw in the hospital and so on. I didn't understand why things should be that way. So I started going to one of the very few ethics seminars that was available at the time was from the Hastings Center. And I went to their seminars, which were all focused on death and dying at the time, and I thought, good Lord, I'm much more worried about the living at the moment.
I think the greatest surprise for me in my journey in ethics and in human rights has been my own limitations. My own culturally induced views of what the world was like. To come to realize that my colleagues in resource-poor nations are not disadvantaged when it comes to brain power. They're only disadvantaged when it comes to trying to do the impossible with nothing. And so what I had to do is to step back and say, wow, what I can learn from these people who are resource poor, but spiritually and intellectually rich, and probably challenged and more accustomed to doing the impossible with next to nothing than I ever was living in a resource-rich nation.